The following is a presentation of the Healthcare Facilities Network. Hello, and welcome to the Healthcare Facilities Network. I'm your host, Peter Martin, president of Gossel Martin Associates and the Healthcare Facilities Network. As always, thank you for clicking on this video. Today, I am pleased to be joined by Scott Cormier. Scott Cormier is the Vice President, Emergency Management, Environment and Care, and Safety with Medxcel Facilities Management. Scott, are you located out in Indianapolis at the corporate headquarters?
I am in Indianapolis, yep.
Excellent. So Scott joins us from Indianapolis this morning. Scott, I gave them your title, but what do you do?
Yeah, that's great. It's a pretty long title. And good morning, everybody. We break what we do up into four buckets. One is emergency management, and healthcare. That means planning for, responding to, and recovering from disasters. Everything from utility interruptions to mass casualty events to even space events and how that can affect our communications. So we really have a broad set of this. And the second thing we do is safety. Now, safety is a really unique term in healthcare because we have fire safety that deals with our fire alarm and fire extinguishment systems. We have life safety that deals with barriers like doors and walls when it comes to smoke and fire. We have patient safety, making sure that clinically we are caring for our patients appropriately. And then there's the general safety that falls under my team. And so what we do is we help our associate safety people investigate any injuries. We do all the OSHA reporting that's required if we have an injury that meets that. We walk the hallways and look for everything from cords to expired equipment and medications. And then we also look a little bit more broadly with safety. So one of the things we do is that we help manage our planning, response, and recovery from active shooter incidents. So since 2013, I've led a federal and private partnership that publishes guidelines that are published on the FBI website on healthcare active shooter. We've really expanded that now to include workplace violence and coming up with unique solutions to that. And then the last thing is environment of care. And as you know, environment of care is everything that operates within the four walls of the facility. So our teams manage and lead the environment of care committees. We have a standardized agenda across the country. We cover everything from medical equipment to utilities to security to our sustainability program and goals. Wow. So that's it in a nutshell.
Yeah, thank you. It's funny is when you said, and lastly, the environment of care. It's like, yeah, that's the last thing, right? With all the accountabilities. So that's interesting, Scott, because I asked Scott to appear on this episode, and he kindly agreed to it. Because at the ASHI Annual, I saw a presentation that Scott and his team gave. And it was regarding a situation in Texas back in 2021 in the Dallas-Fort Worth area where they had cold and snow. And it was a very interesting presentation. And I thought to myself, I'm going to have to ask Scott if he'll appear. So that's why Scott is on. Now, Scott, as you've talked about the different things you do, I mean, you could spend active shooter just as one example. You could do an episode on that. So much of what you do is critical. So I do want to get into the Dallas, but the first thing I want to ask you about, you talked about space events, or you mentioned space events as increasingly space event. Can you talk a little bit about space events and how, I guess, for lack of a better word, intrusive is that becoming into what you do? And is there a recent space event that you dealt with?
Yeah, recently we had some solar flare-ups last month, for example, which had the potential of affecting our communications. And it's interesting. So me and my team spent a lot of time working with the federal government. And so I'm part of the Healthcare and Public Health Sector Coordinating Council. And my National Director of Emergency Management is the lead to work for potential space events. And what we've been doing with the government for the past year now is to look at all space events, whether it's debris, whether it's solar flare-ups, whether it's solar storms, those types of things, and seeing how does it affect healthcare, either directly, communications go down, or indirectly, we can no longer do banking. And then putting together a plan, and the government's doing that for each of the critical infrastructure sectors, so transportation and banking and water systems and all those things. And so we've worked with them, and so that sparks our interest. Our team is always looking for information, so that our leaders can make informed decisions about how we're going to respond.
Yeah, it's funny, since you deal with it, you're probably aware of, but how we've come to count on all those things that we take for granted relative to communication and, connecting with each other. When you mentioned banking, now you have a solar issue, and what happens, people have forgotten how to use the phone, or those old modes of communication are almost out the window these days.
Yeah, and it's so important. As a matter of fact, a few years ago, there was a hurricane that hit Puerto Rico, and so we were assisting the federal government with that. And Puerto Rico is very interesting. 90% of the fuel centers are privately held. So when you go to a gas station in Puerto Rico, you don't see the big signs. It's a local mom and pop shop. And so when we were assisting them, the government said, we're going to focus on healthcare, Scott. We're going to make sure that we are driving healthcare and all our assets are going there. And I said, great, but the sewer system isn't working and they need generators, and I need you to send generators to them. And a water treatment plant isn't working well. And the mom and pop shops don't have enough really money or authority to get fuel trucks to come and deliver to them. So we need them. You need to support the local community as well as the hospitals to make sure that we can recover appropriately.
Yeah, it's all connected when you break it down like that, right? I mean, there's you're not solving for one. There's multiple things that go into that one area. So you have you guys are the largest nonprofit health system in the U.S. See, it's 1,900 sites, including 131 hospitals in 24 states and the District of Columbia. In your role, how do you manage that? That's a big scope. So how do you break it down, and how do you manage it, and how big's your team?
Well, I've mentioned that we have a unique way of addressing safety and emergency management. So I've been in healthcare for a long time, started as a paramedic. So I worked in the pre-hospital field, went inside the hospitals and worked.
How long were you a paramedic for, Scott?
I'm still paramedic. So I entered EMS in 1979. So it's been a few decades. And I actually started, it's interesting, I was a volunteer EMT when I was 16 years old. So my junior year of high school, I went to EMT class. Shortly after that, the state prohibited people under 18 from getting an EMT certification. I don't think it was because of me, but I've always been interested in healthcare and the healthcare aspect. And as I've grown, understanding pre-hospital care, understanding hospital care, and really trying to merge those two things. So we're not doing two separate things, but we're really focusing on improving the healthcare of the community by working together. And so I saw, we'll hire somebody for emergency management, or we'll hire somebody for safety, or typically, hey, you're a facility director, you're also going to do safety and emergency management, or you're ED director, or I've seen administrative assistants given the role of emergency management. And they do that because a lot of healthcare leaders think, well, this is really regulatory.
Yeah.
I mean, it's not that hard to pass CMS or Joint Commission or DNV surveys when it comes to emergency management. As a matter of fact, in my career, I've seen 2 hospitals fail their emergency management, and they were so horrible, they deserve to fail. And so they look at it as a regulatory piece. I don't want to spend a lot of money. I'm not going to buy a bunch of radios. If something happens, we'll figure it out. I know I have to have plans because, CMS requires me to do it. And so we looked at that. And before I came to this company, I worked for another large healthcare system. And we started to look at it from well, what does it really mean when a hospital responds to a disaster? and you close services or you close and evacuate. And how does that affect the community? And how does that affect the revenue? And we found some really unique things. I remember during one hurricane that was coming to a city that we operated in, it was only a category 1, but it was large and slow moving. And we had some buildings that had been built in the late 1800s, early 1900s. And we did something unique. We brought in remediation teams and we embedded them inside of our hospital. And we said, why wait till the storm passes until you start cleaning things up? And when we evaluated that, we saved almost $4 million in damage. And more importantly, we were able to keep 8 ORs and 40 patient rooms open.
Wow.
And so the financial impacts in that were pretty enormous. And even if you have insurance, which everybody does, and even if you have business interruption insurance, it never covers what you're going to lose in revenue from a disaster. But more importantly, when you close services to the community in their greatest time of need, right, you're not really doing a service to them. And so we started to look at a little bit more, which is we had public water outages, and hospitals around us were either going on diversion or closing. And we said, well, there's a great need in the community again, but how can we overcome it? And so we did things like putting water inlets into our water system so we could bring in water tankers, pressurize our water systems, use bottled water for potable water, and stay open full service. And that, again, not only generated revenue, but the public saw, hey, you were open when I needed you, and my hospital was closed. And so we're changing the argument that emergency management isn't a regulatory thing. It's a revenue generating department of the hospital if it's used properly.
This is Peter Martin. If you or your organization is interested in advertising or partnering with the Healthcare Facilities Network, including sponsoring content, then please email me using the barcode in the lower right of your screen. From the trades level to the vice president level, from planning, design, construction, project management, compliance, safety, and security, the Healthcare Facilities Network reaches FM people where FM people. That comment that you made, you said something along those lines during your presentation, and it was, we look at these opportunities as an opportunity to generate revenue and just look at it differently. And I wrote that down. I wish I had my right notebook with me, but that struck with me because it was a little bit different, a little bit different approach. Did you find people who were willing to kind of buy into that vision? Was that a tough sell? Because you changed the way things are done, right? You're very proactive. You're getting that remediation team. How early did you get them into the hospital for that hurricane example?
Yeah, we got them in, and we found we have a timeline, right? 72 hours before landfall, you need to have generators in place. 48 hours before landfall, you need to have remediation teams in place. Okay. So we have this timeline. So 2 days before landfall, we got them in, we bedded them down, we fed them, we had them walk the hallways so they understood. We had our facilities people show them, this is where it typically leaks, and what are some proactive things that we can do, or staging of equipment in those areas. So and I think other hospitals now are kind of looking at that as well, as how can we save damage and recover.
Was that a easy sell to people to change how it's done? And when I say people, I'm talking about obviously within your organization who aren't part of your team, local hospital leadership, others. Were they willing recipients of that message?
Yeah, and it started with when I started at that other company. It was a new role. And they realized what was going on with emergency management and saw that they needed some help. And within the first 3 months of me starting, we had 3 significant events. And so, and prior to me coming, they would hobble together an incident command team. They would give people vests and radios and clipboards, and they'd stare at them going, what am I supposed to do with this? And so when I started, I said, we don't need any of that stuff. What we need to flex our management. We need to provide support to our local facilities, and we need to interact with the local government. And that's exactly what we did. So we simplified the thought of incident command. We still do it. We just simplified the thought of it. And then we made some very good decisions and helped them make very good decisions so that we could continue. And so we built a trust.
Mm.
And so once we had that trust, then we were able to move on to some things like, we really think this would be a good idea. And when I talk to emergency managers, I tell them that you really need two skills: boardroom presence and executive speak. You know, if you need $10,000 for radios, you don't go to your CFO and say, I need $10,000 for radios, because they'll say no. What you say is, as part of our emergency management plan, we are putting a plan together for loss of communications. And there's a couple of avenues we could go with. You know, we've had 3 events in the past year. One is do nothing. And when we do that, our patients can't get in touch with us. We have problems with, you know, getting lab results. The second thing is we can get some satellite phones, but satellite phones are very expensive. Here's the cost for it. And you typically don't use them a lot. And the third thing is we could get radios, and we could deploy radios. Here's our plan. It's about $10,000 to do that. When you give a request in a perspective of all the information they need to make a decision, it's a lot easier for them to make a decision. And so we really have to change the way emergency managers are talking to their leaders and the way leaders understand emergency management and safety.
How far along in the process are you with that, would you say?
Well, when I came to the new company, I spoke up front about what the vision was, and they bought into it. And so very early, we were able to establish ourselves. And a disaster always brings people together. So within 6 months of me starting, we had a hurricane. We came in, and it was interesting. I was working with our hospitals in Florida, and they said, oh, we know hurricanes. We can do it. And I said, okay, well, and then we sat back and watched, and they were a bit disorganized. And so we just brought organization to them. And I said, wow, that's a little bit easier for us. And hey, you know, we really didn't think about that. And yeah, you're right. We should bring a generator in 72 hours before lunch, because but after that, people are all scrambling trying to get it. And we do need national contracts. And so prove your value and then build upon that. So when COVID-19 came around, and we had the second case in the US in January of 2020.
Really? Where was that, Scott?
It was in Illinois. It was at one of our hospitals. And then 5 days later, we had the 7th case in the US, but the first human-human transmission. It was the first person in the US that wasn't over in China that got COVID.
Okay.
They welcomed us in and said, what do we need to do? And for 3 years, we ran a national emergency operations center. We had standardized processes, procedures to get through COVID. And the lessons we learned and the way we were organized, we never had to reuse PPE. We never had to use homemade PPE. And we were able to care for all of our patients. One of our physicians actually went to the White House to talk about using a single ventilator on multiple patients, right? So all that innovation we were able to bring together and manage through COVID.
Wow. When you look, and I'm not asking particulars, when you look back at that, those very early days, like January 2020, what comes to your mind? Is there anything that, not like, I'm asking you to answer the question, not kind of forgetting what you know now, but if you were like, what comes to your mind when you think back to that?
Well, part of my team does information and intelligence. So in the military, I was an interrogator. I worked at the Defense Intelligence Agency. And so information and intelligence was really key. So we saw what was happening in China. We also knew that China is not very forthcoming with accurate information. And so my national director of emergency management and I were always debating, is this going to be bad? Is it not going to be bad? And we have a really good sort of yin yang to ourselves, but we prepare. And so when COVID hit, we were very prepared. We actually were having calls with the federal government every day about what we were doing, what our projections were. We saw things like furlough. We saw things like the need for negative pressure rooms and how do you do that in a regulated environment. And so after those patients went home, and by the way, they really didn't need hospitalized. They weren't ill enough to be hospitalized, but it was a novel virus that we wanted them in the hospital so that we can make sure that we cared for them. And when they went back, when we discharged them, we actually sent people to their apartment building to make sure their apartment was clean, that they had food in the refrigerator, as well as talk to their neighbors and say, hey, you know, your neighbors run the news, but here's the truth of everything.
Wow.
so we could get them back into the community. And then we spent the rest of January and February and March preparing for what we thought would be a wave of COVID, which did come.
It did come. You were right on that one.
Yeah.
I'm going back to, when you talked about the remediation team, but when people say things, it automatically triggers an image in your mind. So I'm picturing a team of remediators in the hospital during the hurricane, just running, like running from location to location as these leaks come in and as different areas of the hospital are impacted. But so as far as that remediation part of it, during the hurricane itself, they're active and working so that when the hurricane clears, you're getting back up online. What does that process look like in the hospital?
Yeah, so we do two things. One is we put our facilities people on a mobile patrol.
Okay.
So they're walking hallways, they have some remediation equipment with them. And then our larger professional remediation team is responding to some of the larger events. So the prompting of all that comes through our facilities people identifying leaks. And then the other thing we do is that we have a leak hotline in our hospital command center. So when people see water intrusion, then they call that hotline so we can quickly get somebody to it. We don't want a very convoluted process. The other thing we do, which seems simple, but before the hurricane, we bring in a rag linen. We don't want nurses using pillowcases and sheets and towels to absorb the water. We need that for the patients. And if we can't get a linen delivery, right, we're going to have to conserve our linen. So we bring in a bunch of rags for people to absorb all the water so we don't have to affect our patient care.
What a great, simple idea.
Yeah.
I mean, it just seems so simple, yet you don't always think of the simple. What else do you guys do that might be a little bit different?
Yeah, again, our approach is, if you look at this, is we're revenue generating, right? We're keeping hospitals open and we're keeping open full service. The other thing we're doing, though, is that healthcare is changing dramatically, and not just in the post-COVID world, but we're moving a lot of services to our outpatient centers. We're doing joint replacement surgeries in outpatient centers that we used to do in the hospital, and you used to have a 3 to 5 day inpatient stay because of it. And, the model for outpatient centers for emergency management in the past has been close, send everybody home, and then when things get better, we'll open. Well, you can't do that anymore because the community is depending upon that outpatient center being open, whether it's a freestanding ED, whether it's an ambulatory surgery center, whether it's a clinic, to care for them. So they don't have to drive the 45 minutes to the hospital. They can get care in their community. And so our emergency management plans have to expand to include those outpatient centers to serve the community and make sure we're continuing to generate revenue. And then the other thing we're working on is sustainability. So a lot of healthcare systems, and us included, are looking at being more sustainable. That means shifting to alternate means of power generation, such as solar and wind, and also electric vehicles. Well, imagine our polar vortex in Texas in 2021, where 6 of our hospitals lost public power, 6 of them lost public water. How am I going to charge an electric fleet? And will they even charge at below 0 temperatures? And so our emergency management plans now are including how to sustain emergency management when you have these alternate power sources and electric vehicles. I had a hospital in Alaska, and Mount Redoubt in 2010 erupted, and ash went all over the place. And we knew we had to do filter changes in our hospital every 72 hours. That's a lot of filters.
Yeah.
What if we had solar panels up there and they were covered with ash, or they got covered by snow in the Northeast? How are you going to continue to generate? And so we're looking at emergency plans in a sustainable world.
Yeah. That brings up a question I'd want to ask you relative to the scope of what you do and where you're located, across the United States. And so I'm up here in New England, just outside of Boston. And, prior to joining the consulting world, I worked for a hospital when we were systematizing, and we made a mistake very early on. And it wasn't was kind of it was a well-intentioned mistake. It was just, we were forming a system, and we looked at our hospitals in a much smaller footprint than what you have. And we kind of equalized all of them as far as snow plowing was concerned, similar contracts, similar sanding, but that didn't work because you have some hospitals that are a little bit further north that need more. And you had some hospitals that were on the South Coast that the snow changes to rain. So we learned from that mistake that you can't do, everybody's not equal. I have to imagine everybody's not equal as far as what they need. I have to imagine do you do that with your hospital planning and look at geographic sections and say, okay, you're on the Gulf Coast, you're prone to hurricanes. You're in the Midwest, you're tornadoes. Do you have to think that way? Change your thinking based on where they are?
Yeah, we do. And, we're a pretty compact unit. So of all the sites we care for, I have about 100 people on my team. I'm a pretty frugal guy, and I don't want a bunch of emergency management people sitting in an office, twiddling their thumbs, having lunch with whoever, waiting for the next storm. So that's why we combine safety and emergency management, because our people are working every day. And when an emergency comes, they pivot and they do that EM role, and it fits well within the environment of care. But we help the federal government develop a risk assessment tool. It's called RISC. RISC is called Risk Identification and Site Criticality, and it's free of charge. A lot of people use what's known as the Kaiser tool for hazard vulnerability analysis, and it's very subjective. And so this risk tool pulls upon 25 years of federal databases to get really detailed information. And it's interesting, when we first started developing this back in 2015, in Oklahoma, we had earthquake as a top 10 vulnerability, and it dropped to 12 because we had a database that showed it differently. So we can really pinpoint what our vulnerabilities are. Now, we love to standardize and optimize. So my EOP template is exactly the same across the country. But there's a third piece that people sometimes forget, which is you have to localize.
Yeah.
And so we're farther up north in New York, for example, so we know we're a bit isolated, and that's going to be different than somebody that is in downtown Baltimore, where we have a lot more assets. The other thing we do too is, when I've looked at emergency management and safety and other large healthcare systems, it's sort of a cooperative. The local hospitals do what they want to do. We meet kind of regionally. Sometimes we standardize things. Within our organization, everybody working in safety and emergency management reports up through my chain of command, not the chain of command of the hospital.
Okay.
And so it's not hard for me to standardize and optimize.
Yeah.
And make sure that what we're doing in Oklahoma is the same thing that we're doing in Tennessee and the same thing that we're doing in Alabama, because they report up directly through my chain of command. And it works well with our C-suites. They get it, they understand it, and they like that we have that consistency.
I was gonna ask you that relative to the reporting structure. Did you implement that when you came in? Did you take it away from local? And how did listen, this isn't talking badly about the C-suite. I remember everybody likes to have that control locally, but they were happy to give that up to you. Did that take any effort on your part to do so, or how did that evolve?
Well, no executive is ever happy to give up power, right? But the way you counteract that is to prove them the value of doing that. And our safety officers are in the C-suites regularly, and we talk to them. And it's interesting that we've built this trust. And as I said earlier, you have an event, you show your value, people trust you.
Yeah.
Our C-suite leaders, if we have an event, our safety or emergency management person doesn't act as a liaison to public safety. Our safety emergency management person is at the head table, as I like to say, which is we're standing next to the incident commander, or we are the incident commander, and we're advising them. And that shows you the trust that they have in their role.
Would you say that relative to creating a structure that you've created and you're still creating, was trust the most important part to build that? What were some of the more important factors to take a program nationally and get the C-suite locally on board with what you're doing?
Yeah, in any case that I've seen, the first thing is that senior leadership has to buy into it, and they have to support it, because you're going to get grumbling.
Yeah.
So if it becomes an enterprise strategy of what you're going to do, it's a lot easier. And sometimes you have to lean on that.
Yep.
Hey, I know you want to go off in a different direction and have our safety in the in-person do something different. And we'll listen to that. And if it's great, we'll change it across the country. But we have a standardized program, and we have a standardized program because we've optimized it. And then again, you have to have an event and build a trust, and they have to see the value that you have. That is really key. And being at that head table, I've been to a lot of hospitals where they've stood up incident command, and the emergency manager is sitting in the back corner of a room, and other people are talking, and they have better information than everybody else talking. And that information intelligence is kind of key as well. I mean, imagine during COVID, all the information coming out from CDC, the World Health Organization, local news, national news, Facebook, social media. And what do you do with it? And so we learned very early on, we need to control the information. And so we sent out a newsletter to all of our hospitals and clinicians and our staff every day, which said, here's what you heard in the news, here's what it means, and here's our direction. And so when you control that information, people are going to build trust in you.
Yeah. This concludes episode 1. Please return to the Healthcare Facilities Network in the near future to view episode 2. And as always, thank you for watching.